Hi all, welcome to Physio Exam Buddy. This video is on heart blocks. We all know that about the conducting system of human heart. Normally, SA node is the pacemaker. If it is blocked or diseased, then the potential pacemaker with the next highest rhythm will start to discharge impulses at a natural rate. And the tissue with the next highest rhythm is our AV node. When this AV node is blocked, bundle of his produces impulses, and if it is diseased, then the next one, that is the Purkinje fibers, will produce the impulse at a much lower rate. So those parts of the conducting system other than the SA node or AV node that can take over when the SA node or AV node are depressed. They are known as the latent pacemakers. Now about the heart blocks. Heart block means any disturbance in the conduction of the cardiac impulse from the SA node to the heart cardiac muscles. Heart blocks is broadly classified into SA nodal block, AV nodal block, and bundle branch block. AV nodal block is again divided into incomplete heart block as well as complete heart block. Incomplete heart block includes first and second degree heart block, whereas the complete heart block includes the third degree heart block. First, about the SA nodal block. This is a very rare condition, and here the SA node will become diseased. So the next potential pacemaker, that is the AV node, become the pacemaker. And in SA nodal block, the ECG, it is characterized by cessation of the P waves. That is, there is stoppage or no P waves. And the QRS complex, that is QRS complex, it will be slowing. That is, the gap between the QRS complex will increase. Next, about the AV nodal block. We all know that AV bundle or bundle of His, it is the only means by which the impulse passes from the atria to ventricles. And the AV nodal block can occur in conditions like ischemia, compression, inflammation in case of diphtheria or rheumatic fever, or by the extreme stimulation of the heart, especially in carotid sinus syndrome by vagus. AV nodal block is divided into incomplete heart block and complete heart block. So first we will see about the incomplete heart block, which is again divided into first degree and second degree heart block. First, about the first degree heart block. All atrial impulses reach the ventricles in case of first degree heart block, but there is a delay in the conduction. And in the ECG, you will get a prolonged PR interval more than 0.2 second in first degree heart block. Next, about the second degree heart block. Here, all the atrial impulses are not conducted into the ventricles, and the second degree heart block, it is again divided into Mobitz type 1, also known as Wengi-Back phenomenon, and also Mobitz type 2 block. Mobitz type 1 or Wengi-Back phenomenon. It is a form of second degree incomplete heart block in which the PR interval will lengthen progressively. That is P to R. So the PR interval will lengthen progressively until a ventricular beat is dropped. You can see here between these two P's there is absence of the QRS. So the PR interval will prolong progressively until a ventricular beat is dropped. Usually this condition, it is due to impaired conduction proximal to the bundle of His. PR interval of the cardiac cycle that follows the each dropped beat is usually normal or only slightly prolonged. That is the characteristic feature of the ECG in Mobitz type 1. That is a form of second degree incomplete heart block. Next, about the Mobitz type 2 second degree heart block. Some atrial impulses are not conducted. So, the ventricles will beat for every second or third atrial beat. That is why it is also called as 2:1 block or 3:1 block. And the block is usually below the bundle of His. An artificial pacemaker is frequently implanted as the block is usually below the bundle of His, so that the adequate heart rate cannot be maintained if the block goes below the bundle of His. So most cases of Mobitz type 2 block is treated by implantation of the artificial pacemaker. Next, about the complete heart block or third degree heart block. Here, the conduction from atria to ventricle, it is completely interrupted. So, the ventricles beat at a lower rate independent of the atria, and this type of rhythm, that is independent of the atria beat by the ventricle, it is known as the idioventricular rhythm arising in the bundle of His or in the distal conducting tissue. Correspondingly, the P waves and QRST complexes bear no relationship to each other. And the AV dissociation can be due to AV nodal block. In complete heart block or third degree heart block, conduction from the atria to ventricle is completely interrupted, leading to AV dissociation, which can be due to either AV nodal or infranodal block. AV nodal block usually arises due to diseases of the AV node. Here, the remaining nodal tissue becomes the pacemaker and produces impulse at a rate of 45 per minute. Whereas in infranodal block, the block in the conducting system occurs below the node. That is mainly due to diseases in the bundle of His. The damage to this bundle of His can either occur due to surgical correction of the congenital interventricular septal defect or because of septal myocardial infarction. The ventricular pacemaker is located more peripherally in the conducting system, and the ventricular rate, it is lower and it averages around 35 beats per minute, but in individual cases it can be as low as 15 beats per minute. Next, about a condition known as Stoke-Adams syndrome. It is just an attack of complete heart block accompanied by fainting. If the complete heart block develops suddenly, the atrial impulses are not conducted into the ventricles. Ventricles will stop contracting for about 5 to 30 seconds before idioventricular rhythm get established. So the brain cannot be active for more than 5 seconds without the blood supply. The resultant cerebral ischemia causes dizziness and fainting. But the slowly beating ventricle usually pump enough blood to allow recovery from this faint, which occurs in Stoke-Adams syndrome. Next is about the right or left bundle branch block. In bundle branch block, the excitation passes normally down the bundle on the intact side and then sweeps back through the muscle or cardiac muscle to activate the ventricle on the block side. Therefore, the ventricular rate is normal in this case, but the ECG shows a prolonged QRS complex as well as a deformed QRS complex is a feature of right or left bundle branch block. Next is about the hemi block or vesicular block. That is, block occurs either in the anterior or posterior vesicle of our left bundle branch. And it can be either bivesicular or trivesicular block, that is a combination of vesicular as well as branch blocks. Next is about the artificial pacemaker. They are usually implanted in case of complete heart blocks. So here external energy sources can be used to stimulate the heart in symptomatic bradyarrhythmias. Because as the pacemaker shifts to more periphery, the heart rate will become decreases. So in order to stimulate the heart, external energy sources are used, which is known as the artificial pacemaker. In artificial pacemaker, the electrodes are usually positioned in the apex of the right ventricle for ventricular pacing, and in case of atrial pacing, it is usually positioned in the right atrial appendage, or it can be placed on both these sides for keeping the atrial as well as ventricular pacing. And the leads are then connected to the pulse generator implanted under the skin below the clavicle. So that is about the heart blocks. Thank you for your patient listening, and keep on watching Physio Exam Buddy, which makes your physiology exams more easier.